Jamile, can you comment how you assess iron overload in your transfusion-dependent patients?
I mean, I'm very cognizant of the fact that iron overload is a consequence of transfusion-dependent state in MDS, but I have to say that I grapple with the same issues like all of you that relate to when should you actually start looking at ferritin levels, and we don't have any specific trigger or a guideline. You have to sit down and count how many units, but I think it's fair to say most people who come to my clinic will get a baseline ferritin evaluation, and then after the guidelines tell you 20 to 25 units of blood, somebody may become iron overloaded. So I think periodic assessment of ferritin is something that we must keep in mind. And as you know, the guidelines for initiation of iron chelation varies from by recommending bodies, and again, nobody knows what the magic number is, but again, if you have someone who's going to be transfusion dependent or red cell transfusion dependent, then you can only imagine that ferritin level is going to continue to rise, and perhaps we don't have to wait until it gets to 2,500 as per the NCCN guidelines, because then it's really difficult to kind of catch up with that number. And what you would ideally like to do is to bring it down below 500. At least that were the clinical trials that took place with the iron chelators in MDS patients. You wouldn't want them to be below 500 for the theoretical reasons of making them iron deficient, but generally speaking. And then of course you have to sort of correlate your dosing according to their transfusion need, which is actually what was done in clinical trials as well, looking at chelation. So these are all very challenging issues that you deal with.
So the common tools you use are the number of transfusions as well as serum ferritin.
And serum ferritin.
Are you, any of you using MRI measurement of liver iron concentration?
We actually did a clinical trial at Weill Cornell, which I don't know if we've ever published the data, where we did T2 star MRIs on patients who had had 50 or more units. And interestingly, very few patients actually ended up having a positive T2 star for cardiac iron deposition. But I say that with a little concern because one of the patients who had a negative T2 star MRI actually came in 3 months later with severe congestive heart failure and on autopsy had profound iron overload. So I don't know if we have the best, if our technology is really where we need it to be to assess cardiac iron overload.
So I think that's an important point. The standardization of all these techniques is critical, especially for cardiac MRI, because if the center does not have expertise, you could miss some iron overload in the heart.
So for me, the issue, obviously, like, I think the iron overload, nobody will disagree that it's a problem in patients with MDS. And as Jamile mentioned, usually patients, when they get to 15, 20 units of blood, each having like 200 milligrams of iron, you are at the threshold where you could get iron overload. The question how to monitor that, ferritin is the easiest we use in practice. But like also, if you look at those patients, 1/3 of MDS patients would come with high serum ferritin at diagnosis, which could really reflect kind of downregulation of hepcidin and the body sensing the anemia, and actually you're almost getting more iron absorption. It could reflect the transfusions, or it could be an inflammatory marker. So I think it's reasonable to check baseline when the patients are diagnosed and then follow after that. And sometimes I see this unnecessary monthly need. I don't think you need to check ferritin monthly and you don't want to check it in a state where the patient is in an inflammation in the hospital. You want to do it in the clinic, maybe every 3 to 4 months, monitor that. The other techniques, obviously, we don't do liver biopsies in patients with MDS because of the bleeding problems. The MRIs for the liver or for the heart are not widely used. So actually, in real life, we are using ferritin. As Jamile mentioned, the guidelines vary on this. You have the NCCN guidelines saying you consider that when the serum ferritin level is above 2,500. The MDS Foundation says when they are above 1,000. So there's some kind of no agreement between even the guidelines.
So what do you do?
Based on what?
What do you do in reality?
I'll do somewhere in between.
I think you have to look at the patient. If you have a patient where you know that they're going to need ongoing transfusion and you really can't see an end to this process, when they're hitting a serum ferritin of 1,000, it's really time to jump on the bus and to start thinking about treating that. If you really are hoping that you have a modality where they're going to be transfusion dependent, you may not have to be in such a rush. You also have to look at the tolerability of the drugs in older patients, especially who are our constituency. You can't start a high dose of iron chelation all at once and believe that they're going to tolerate that therapy. It really has to be started at a low dose and slowly titrated up. So for a long time, you're going to be happy just to keep them at the same level without their ferritin rising. You may not be able to make a lot of progress in decreasing their ferritin as you accommodate them to a dose level where they can really tolerate the medication.
I couldn't agree more with that statement because especially when it comes to iron chelation, you need extended duration of therapy. I mean, in the EPIC trial, you needed 12 months, or I should say the primary endpoint was assessed at 12 months. So you really need something that's tolerable, that people can take for an extended period of time, but keeping in mind that you may have to alter the dose accordingly, depending on transfusion needs.
I think we usually completely focus on our potentially disease-modifying agent, but it's true that we need also to keep in mind that this therapy with iron chelation needs also clearly our attention, and to be sure that we manage dosage, potential side effects of this iron chelation agent accordingly, because it can be a real challenge for the patient.
And you don't want to put them on a homeopathic dose of
Correct,
iron
yeah.
chelation
Yes.
and just leave them there without really having a sort of dynamic improvement in that dose. So it's tricky, and it really does require full attention as a clinician.
And
to that.
there's definitely a learning curve, like with any disease-modifying agent, with this iron chelation agent too. And it needs a little bit of time to really manage correctly these patients.